Hello, everyone. My name is Dr. Alex Milspaw, and I'm going to be joined here shortly by Dr. Leishear. Hello.
Hi.
Leishear.
How are you doing?
Good. Wonderful to connect with you.
Yes. Great to connect with you. Thank you so much for this opportunity.
Yes, ditto. It's lovely to work with you, and I know we connect on in regards to a variety of different patients that we work with.
Yes.
And so our amazing social media group has us talking today about healing sex. So while it's going to be a little bit more dialogue, I think those that are watching as far as us talking about what are all the differences that cause painful sex, and how PRM can help on the medical side. And we can go into what we can do on the behavioral health side in terms of the one-on-ones as well as the workshops and what we offer.
Perfect.
Anything else you would add?
No, if you want to just, want to have me just go right into kind of what we see as far as symptoms, symptoms of painful sex, how the causes, conditions and all that.
Yeah, let's jump right to the medical meaning of maybe when patients first come to PRM, how does that usually present? Do they usually talk about that right off the bat, or and as others?
That's a good question. So either way, so sometimes that is really their main complaint is really pain with intercourse, and pain with penetration sometimes, but sometimes it's not. Sometimes it still is something that they're suffering from, but maybe they're presenting with painful periods. Sometimes they're presenting with bladder pain with urination. But when then I ask about, how is you have pain with intercourse, either during or after, and they say, yeah, maybe it's always been a little bit painful. So we talk about that, and how that is something that we can treat, and we can also treat with their main complaint as well.
Yes, I love how I see similar things. Sometimes they'll come in and they will say right off the bat, I have sex with, I have pain with sex, or I've always had pain with sex, and that's what I want to work on. And sometimes they'll present with pain in other parts of the body, the lower hips, or they'll talk about other regions of the pain area, and then I'll ask if they have pain with sex. They, no one's ever asked me that. Yes, I do.
Right.
So it's almost not expecting us to be able to talk about sex, let alone.
Exactly. Yeah, I mean, it's a difficult thing to talk about, and maybe, I think there is part of it that maybe if you've always had pain with intercourse, or maybe it's supposed to be, a little bit uncomfortable, or, if you've always had that experience, then you start to normalize it. So I think it's just, when patients come to us, I think part of that is just having a discussion, having patients feel comfortable about talking about it, because it's difficult to open it up, to your providers. But then I've had patients say that it's difficult to even talk to their partners about it, because, there's a lot of emotional things that are attached to it, embarrassment or anxiety, stress, that kind of thing. But, I really want, patients to have a safe space to talk about it, because that's the way we can really get to the bottom of it and kind of get them on a path to healing.
Yes, and I love all the things you mentioned in terms of helping them know what questions to ask, even.
Yes.
If it's been part of their experience, they've never had an opportunity to talk about it, they don't know what to ask, and they don't know what they don't know.
Right.
Presenting them with some of the information that we're going to present with them today, and then sometimes I'll say, over the next week, write down your questions. Any questions you could think regarding sex, and what might you want to ask your partner? What might you want to, ask as provider? And because sometimes the nervousness of talking about sex, let alone the painful sex, can almost shut down the nervous system, forget all the questions that they have in.
Yes.
And so that's what PRM does as part of our treatment program. We say, write your questions. Bring them.
Yes, bring them. We want your questions. The more, this is with anything, the more you understand about your body and what you're going through, the better you can help yourself and really help with treatment.
Yes, and I know Esther Perel puts a really great 127 different questions that can almost be like conversation starters. People can both ask themselves as well as their partner, because we don't even know where to start. And we can also be good at pointing things out that we think are wrong or things that aren't working. We forget to also look at what is working. So let's start with what's not working. So when people come in with painful sex, what is not working, or what's everything involved that's going on there physically?
What can be a variety of different things, and so people can have just the symptoms, genital pain, or it can really be any pain in the pelvic area. You can have pain in other areas that maybe you have back pain or hip pain, and that's going to be uncomfortable, just having the act of having sex. So it all really plays a role in that. So people can have, it's general pain. It can be internally. So for women, it can be internal vaginal pain. It can be really deep pain. It can be pain on the opening of the vagina and the vulvar area, or that opening of the vagina. So I really always ask patients, is it with insertion, entry? Is it deep? Is it both? Sometimes, often is both. But to really pinpoint that, I think it's important. And then also sometimes it can be painful with different positions. I think that's important to recognize and really talk to patients about. Sometimes it's the area between the genitals and the rectum, known as the perineum. That can be a painful area as well. So really, it also bladder pain, urethra. Sometimes if GI issues are involved, sometimes people can have rectal pain, but sometimes, we'll talk about that more, but that can also play a role in pelvic floor dysfunction as well, so tight muscles and nerve pain, but all of those areas. Yes,
so it sounds like PRM really helps educate patients on all the different pieces that go on in that, all the pelvic bowl. And sometimes just that basic anatomy is so important, because didn't get it in 5th grade. We started getting it after that, where, I talk to patients about how so many of us are trained to just zoom into our part of the body that we're talking about or looking at. We forget that they're all neighbors when it comes to the pelvic floor, right? So it sounds like you ask about the bladder, the reproductive organs, and the bowel, as well as all the nerves and muscles that surround those areas.
Exactly.
Sometimes like that shock factor of showing people a picture of, okay, this is the picture you see in your GYN office, where you see, first of all, not a quarter size image of the bladder and the uterus and the lower back. Actually, the uterus isn't even that high. It's lower down.
Yes.
But the picture of the nerves and the muscles, and they're like, whoa, all that stuff's in there?
Yes. There is a lot going on in not a lot of space. So really anything, if you think about, the pelvic floor itself. So the pelvic floor, it's really like a sling or a hammock, really going from that front pubic bone to the tailbone in the back. So it kind of really supports all the pelvic organs are right on top. So it supports your pelvic organs, your pelvis, your spine. So it's doing a lot of supportive functioning, but then also it is, it's sexual health, your sexual health, which is not only, it's intercourse, it's orgasm, it's pleasure, it's arousal, it's complicated things, but then also it's the urinary symptoms and the GI symptom, GI end of the colon, that kind of thing. So all of these things can really play an underlying cause. So when you talk about what are the underlying causes of painful sex, it really can be anything affecting those pelvic organs or the pelvic floor itself. So, looking at gynecological, urological. So in women, really sometimes endometriosis can play a role in painful sex. Other things like pelvic organ prolapse Other thing, vulvodynia, which is just pain in the vulvar area. Sometimes infections can play a role, whether it's yeast infections, urinary tract infections, sexually transmitted infections as well. And then sometimes to talk about the GI system, I mean, IBS, hemorrhoids and things like that can all cause kind of this tightening of the pelvic floor, this guarding tightening of the pelvic floor. And then you have tight muscles. That in itself can cause pain, which is a lot of what we treat at PRM as well. But then also these tight muscles really cramp the space around the nerves. So it irritates the nerves, doesn't give the nerves in the pelvis enough space to properly function. And over time, you get this irritation of the nerves and you get pain in that nerve. You actually get inflammation of the nerve and then a sensitivity of the nerve. So things that used to be, not usually painful, now are painful. Things that are, what's normally maybe a little bit causes a little bit of pain, now causes a lot. So that essentially that volume has been turned up, and that kind of is what happens when you get that nerve sensitization. So that sensitization of the nerves actually happen in the pelvic area. Over time, it really happens in the brain. And that's, a lot of times it's really why we're doing this interdisciplinary multimodal treatment approach. And part of what, Dr. Milspaw does really helps us with that mind-body connection, really to down-regulate that upregulated system.
Yes, perfect. Perfect. So what I love is that you pointed out not only the cumulative traumas, I'll say, physical agitation of those nerves from, it could be from STI, from UTI, from patient, from periods, as well as from athletic injuries in terms of how the body tends to compensate. Right? So many people that have had either a few different ACL tears or a few knee surgeries, or they remain on a crutches for several months, and then as the body compensating, it's the side of the hip that's been trained using crutches. One side of the hip, maybe someone is always leaning to the right. I know when I drive, I tend to lean to the right, and then after an hour drive, yes. So, but the physical agitation cumulatively over time builds up inflammation around the nerves.
Yes.
Which creates the physical sensitivity or the heightened sensitivity. And it's my understanding that with inflammation, the myelin on the nerve way, which then it's kind of more raw wire, kind of how I know I've understood it, explained it a little bit to physicians, and that's one of the things that PRM's injection help with. Right? Really helps decrease that inflammatory soup so that myelin can grow. Is that correct?
Yeah, sometimes it's really just that irritation of the nerve, just really that cramped. It doesn't have to be. People will say entrapment. Usually, it's really just an irritation, just in those tight muscles, the fascial restrictions as well. Sometimes if people have had surgeries in the area too, that can cause inflammation and scar tissue. So it's really, we use this approach with pelvic floor physical therapy. So our treatments, whether it's a muscle relaxant suppository, the injections, they all really make space for the nerve in the pelvis. So whether it's really lengthening those tight muscles, kind of making those fascial restrictions improve, so making space for the nerves. And then the nerves can heal themselves. It's almost like taking those nerves from like an urban environment to the countryside. So they have space. You know how it feels so nice when you go, to take a hike and get that fresh air. The nerves need that in a sense too. It also opens up blood flow. It improves blood flow as well. So making space not only for the nerves to heal themselves, but also improving blood flow to the organs, to the muscles and nerves really does help with this pain and the dysfunction.
Yes, and that's a great great visual, and we visualization certainly in the mind, and we know that when we not only visualize something happening, like, okay, there was a big inner city in my pelvic floor, and I want to create a spacious Montana Yellowstone type of feeling. Right? The mat in and of itself can actually help relax muscles and create space. But we also know that when we think about the part of the body, breathe into the body, that increases circulation in the body. Breathing there, visualizing, pulling in the mind ability to visualize what we want the body to do, more effective when we utilize metaphors. Sometimes more so than thinking literally, right? Because the mind can get in our way and say, well, these are all the reasons why that can't happen.
Yes.
A lot of amazing things the body can do when we get our mind set on it.
Yes, definitely. There's definitely that, mind-body connection, which I see, and that's why, especially in this complicated, painful intercourse or just chronic pelvic pain in general, it really is, it's peeling away the layers of an onion. It's really assessing that, the mind, the body, the really physical and emotional, it really ties in to everything. And it really, incorporating both really does help to have the most effective treatment.
Yes. And I'm sure you see what I see in terms of the location of the pain, right? In the pelvic, and as we've already mentioned, is a secret place, a hidden place, part of the body that people aren't allowed to talk about. And so feel very alone, isolated. But it's also a necessary part of movement. We can't rest part of the body. So if I broke my leg, rest it and it can heal. Sometimes I say it takes longer for the pain to heal because we can't fully rest the way we want to be able to. And the stress around it is that much more stressful for people. Have to, like, how am I gonna pee? How am I gonna go to the bathroom? How do all these things? But then when it's sex, I find that somebody's relationship involves sometimes so closely around function, and some systems about their lovability, attractiveness can focus so much around their function, being able to have a certain type of sex, such as penetrative sex, and really makes them who they are. And and then as far as brain mapping goes, they have that whole how they love themselves, about themselves, and what's the depth of the relationship.
Right.
One can't have sex in that relationship, then we need to look at the relationship.
Right. I mean, it really is. I mean, sexuality and sexual function and even pleasure, arousal, that kind of thing. I mean, it's your sense of self. So when that is not functioning the way that you want it to function, it can really kind of have somebody feel like, decreased self-worth, feeling of anxiety. I've definitely had patients say that they felt embarrassed, and it affects relationships. It affects intimacy, because while maybe painful periods or certain types of pelvic pain may be just affecting you, this is really affecting your relationships, your ability to have relationships. And I've definitely had patients come in, maybe they come in with their partner. I've had couples where they waited till marriage to have intercourse, and the first time they tried, there was pain. So I think it is, it just affects everybody. It doesn't all just affect the person with the pain. It affects their partners as well. So that's definitely something to be mindful of.
Yes, and what's great is that you being that PRM, that space for them to start talking about it. I think when it comes to the neural mapping and the brain mapping, when we don't have practice thinking about it or talking about it or even being curious about it, we don't have a sense of foundation to talk about it. and or even kind of where to go of
Right.
normalcy around injuries or pain in the parts of the body. So we've thought about it to some degree, but with the brain, when there's this underlying feeling of shame or secrecy, it just wakes up a whole different ballpark on how the brain reacts. Let alone the point of the more that part of the body is stimulated, it not only gets sensitized in that part of the body physically, but it also gets sensitized in the part of the brain, because the brain's main job is to keep us safe. And so it remembers fear-based and pain memories more easily, and it prioritizes those memories more so than the good stuff. And so when we have when a part of the body that's not only in pain but also has an association with shame or secrecy or something forbidden, then the brain really amplifies it. So part of the Retraining Your Pelvic series, as well as the Reigniting Intimacy series, is focused on how do we not only understand physically what's going on, relax those muscles, but how do we think about it differently? How do we retrain the brain out of that sensitivity? And part of that is exploring all the erotic, pleasurable zones all over. Right? People tend to hone in on called the T zone, like how acne happens.
Right. Yeah.
There's the T zone of sexuality. Yeah. Go straight for the bullseye points. And I think women in general have said for years, centuries, there's a whole other part of my body here. Thousands of
explore it, right.
But we know that pleasure and activating those pleasure circuits actually helps quiet down the pain circuit. And so we go back and forth between not only calm down the pain, but also how to increase the pleasure. And it's saying that, with physiatry, what I love about physiatry is you talk about function. And let's not only talk about what's not functioning, let's focus on everything that is functioning. And as far as brain mapping, can also help inform those other parts of the body that says, hey, if the nerve heal here in my knee or my foot or my hand is possible, but if that's capable of healing, the nerves in my vagina are also capable.
Yes. That's correct. And I'm a physiatrist. Another name is physical medicine and rehab. All the physicians at Pelvic Rehabilitation Medicine are physiatrists. So it's focused on function. We want to get you to the highest level of function. It really is a quality of life specialty too. And part of that is sexual health, sexual functioning, because, that is a part of our lives. So we want you to get back to what you want to do, and that includes intercourse and pleasurable intercourse. So I'm really fortunate. I love this specialty because it really is this quality of life specialty and focus on function. And I love that it's multidisciplinary. Even in my training, we work with therapists, physical therapists, all kind of other specialists that really, we kind of have this comprehensive team, so in pelvic pain, we have the gynecologist, the urologist, GI as well, definitely pelvic floor therapy, psych, behavioral health as well, such an important part of it. But it really is all of these areas that we really focus on. Yeah.
I agree. And I think where, our roles are lucky. We really help remember, as a provider, but we help remember to zoom out and look at their whole body is connected. And people can sometimes feel overwhelmed of, okay, I see this specialist, this person, and this person. They can feel like much. But when they zoom out and they remember that, oh yeah, it's all right. I can't do this part of the boat without fixing this part of the boat and expect it to be okay. I've got to heal all the patterns, the whole system. And between the time that I am able to provide with patients one-on-one is more time than most physicians are able to spend with them. But I think what the physicians at PR good at is just putting it all together and saying, okay, this is why I'm sending you to Dr. Milspaw. This is why we're sending to the nutritionist, why we're sending to or physical therapist, and we're going to communicate about your care.
Yes.
Not only understand how it's all connected, but make sure that we're asking questions about, well, are you managing your anxiety, or there's stress in your relationship? Your vagina is not going to open if you're mad at somebody, right? Let alone feel safe, right? Safety is so important, and
Yes.
feel safe to talk about it. They're not going to, system isn't going to feel safe to go there. And so a lot of the Reigniting course is about saying, what's the status of your relationship, right? Have you talked about the meaning behind sex, right? If you know, as I said, some people wait for marriage to be able to start having sex, and then there's so much more power in that inability to. That mean that we're not honoring the marriage, that mean that a good enough couple, that mean, right? We want to challenge what are all the meanings I'm placing on body's current status.
Yes.
And really putting it on all the good stuff that really is more long lasting and leads into how it responds to different stuff.
Mm-hmm. Yeah, I mean, it's about really looking at the patient as a whole. I mean, I do a musculoskeletal exam. I'm looking at not only the pelvic floor muscles and the nerves in the pelvic area to see if there's dysfunction or pain there, but also if there's any underlying, issues. So hip issues, hip impingement, labral tear pathology. Is there anything from the spine, lumbosacral spine contributing? Is there a hernia, a sports hernia that can be contributing? Anything that's really contributing to the imbalance of the muscles and nerves in the pelvis can actually be symptomatic, can be painful, can really cause ultimately pain with intercourse. So we're really looking at all of the pieces of the puzzle, trying to put everything together, because it is complicated, but really, focusing on a lot of different things. And just to kind of touch on, just even with painful intercourse, it really can happen anytime. It can happen the first time somebody has intercourse. It can, for women, any type of penetration, whether it's a tampon, a gynecological exam, a finger, things like that, or intercourse, or you could have, pain was the first time you had it was fine, and maybe later on in life, after a baby, having a baby, after surgery sometimes, for women, sometimes after hysterectomy, and then sometimes even after menopause. So it can be related to hormones. That can be an underlying cause. So there can be just vaginal dryness. There can be a thinning of the vaginal walls that can come into play. So that, I think, really teaming up with gynecologists and coming up with the best treatment as far as those types of hormonal therapies is really helpful. Yes,
and a lot of what you're saying is helping, again, people understand what are all the pieces that are going on here. They're a pattern, right? So if there's, so people can keep track of when is their pain, and we're talking about both men and women here, right? So there's with either as well as pain with arousal. And some if women haven't had penetration, they might know they feel pain or they anticipate pain because there's pain with arousal or orgasm, pain with erection and things like that. But there's also the pattern of it. So is it all the time? So every, no matter what time of the month,
right?
To your point, it's that can deal, correspond with hormone levels, menstrual cycles, and that sort of thing. But I also find that people really start to keep a diary of it correlated with constipation or bowel function, or I only do that 10-mile run on the weekends, and that's when I have pain with intercourse or during the day when they're not stressed themselves. So again, so many different pieces, and to have people really think outside the box of what could be affecting in there.
Yes, definitely.
Right? We're feeling good when my relationship feels positively. It doesn't hurt, but when things, or I've been stuck in a pandemic and haven't been able to leave my house for 2 years.
Right.
Right? What's happening?
Right, exactly. I mean, sometimes just stress, sometimes people have more tension in the pelvic area, the pelvic floor. As I talk about patients with, sometimes where do you hold your tension? Where do you hold your stress? And sometimes people, have it in their neck and their shoulders are up to their ears and they have a lot of neck pain, headaches, but sometimes you can have that tension in the pelvis, the pelvic floor, and it's just really, teaching techniques that'll try to relax that area. Yeah.
Do you ever invite partners ever come in for the appointment?
Yes.
Can also be educated with the same information that you're giving the patient as far as just basic anatomy of this, all this, the hip pain and the back pain absolutely connected to the muscles and the nerves causing this.
Yes, absolutely. So we have quite a few of our patients who come in with their partner, which I always tell that partner, you're just wonderful. Just by being here, being so supportive, this is helping your loved one. So yes, so we encourage that, and I always I love to have the partners questions, and because and then I think that the partner just understands more, when even when they come for the initial visit and I'm saying, okay, well, this is what's happening in this muscle and nerve and the brain, and this is why you're having pain, and I think there's other factors, so that the partner actually understands to the highest extent, so that not only my patient, I think, appreciates and that their partner is willing to come and help them on this path, but then the partner themselves understands there's a physical component that is treatable, because I think a lot of the patients, unfortunately, have been to a lot of providers where they really haven't, sometimes they say it's all in your head or you should relax, and it's really, most of the time, it's really not that simple. So a lot of the providers, maybe they've seen, maybe probably 3 to 5 providers on average before they come to see me, and just by acknowledging their symptoms, saying, yes, there's actually, it's definitely, there's a emotional part, there's a psychological component, but there's a physical side that needs to be treated as well. So I think just acknowledging that really does help a lot of patients, just even initially.
Hugely, absolutely. And I try to explain to partners too that they've become guilty by association, right? So if the person has pushed through the pain, and so they've had pain, if their partner is present, which normally they're now associating them with that pain. And sometimes over time, patients, their body will actually retract if their partner give them a kiss or comes to give them a hug or even just comes to sit down.
Right.
And again, if that's not talked about, then the partner, that personal, oh, you don't want to connect with me and all that stuff. And sometimes the patient doesn't even understand their own body's reaction. Like, well, I don't know why I don't hug them anymore, why I feel an allergy to touch, right? They literally kind of get an allergic. And it says, well, if A plus B equals C, right? If learn that any type of intimacy or close leads to sex, which then leads to pain, the body's going to say no to all above because it's trying to protect them from that pain.
Yes.
And so really, the reason I led the workshop, Reigniting Intimacy, is because we're talking about intimacy, not penetrative sex. We can get to sex, but if that's the goal, and partners that come in and say, so just tell me when you're going to my partner so we can have sex. It's like, okay, let's just look at how that question made sex more of a priority than your partner feeling safe, your partner feeling like she's enjoying it, partner feeling that she's more important than what her vagina can offer, right? So sometimes I'd have to just mirror it back that says, let's look at framing it, first of all.
Right.
What is really a priority? And so I'll even talk, okay, if sex is the doorway to something, that's actually more important. What do you get from sex, or what do you even imagine getting? And that's when I'm feeling closer. I imagine feeling like we're real. I imagine feeling normal. I imagine feeling loved and pleased and desired. All those different things. And it's like, okay, we can get to feel that, even if we can't get past the sexual pain. Now, we know that the body's capable of healing. But it's really, again, almost zooming out and saying, why, why are we putting off, vaginal intercourse or just penetrative intercourse, regardless of ship? But, to really get people thinking about how important they're placing penetration. Not to take that away if that's really important to them. I want, we can honor the goal, but having all the other stuff as a more important goal, functioning and connection and closeness and intimacy, that's exactly what leads the vagina to open. Right?
I agree.
Sure.
I agree. I mean, it's like, you're right. The vagina wants to be in a safe spot, right?
Right.
And you talked about it earlier, where the brain has this, it just wants to protect yourself. I mean, that's good. That's good for, how we survived as a species. It's good that is kind of, our protection kind of goes, but it can be a barrier in certain instances, so right, if you've always had, pain with sex, or then you can have this fear even before going in, or if you had trauma before, whether it's physical, emotional, sexual trauma, abuse, that plays a role into it as well. And even trauma as far as like surgery or medical procedures, because that can be traumatic.
Yes.
So that plays a role as well.
That's huge. Yes. And the memory is stored all over the body. Memory's not only in the, also in the muscle. I think it was the father of physical therapy said, our issues are in our tissues. So not, when people say, well, does that mean it's all in my head? No. If your body has a memory of danger signals, which it's even brain labels it danger signals, but if it has a memory of cumulative stress or trauma, surgeries or injury, that all of that leads to that wind happening. And so the sense of safety is so important, because sex is such a powerhouse when it comes to having a conversation and with anyone, let alone a partner. There's such a pass-fail approach to sex, right? Not only did it work, but was it good for you? Was it good? But there's a test, and that's so in our culture of comparing. Even if you don't have sexual pain, there's comparisons of, am I having good sex? Am I good at it? Is this right? And couples talk about that, and then so that's out there anyways, let alone when we have pain. Sex can become so clinical. Is it working? Did it? Are we having fun yet?
Right. Right. It's clinical. True. And, there's expectations on both ends, whether it's, and cultural, what you believe culturally or religiously about sex. I mean, that's a whole nother thing. Socially, what are your own, sexual goals? So I love that you mentioned intimacy as not only intercourse. I mean, for some people that may be, something that's what their goal is, but, there are all these other, it's like a spectrum, of really sexuality, and people can have, like you said, there are other erogenous zones, there are other things that you can work on and lead up to, whatever is as a barrier, basically.
Yes, absolutely. And so, knowledge is power, right? So something that providers like you and I can offer is not only the anatomy lesson, it's all connected, and the how and the why, all these different providers together,
right? That
safe space of having that conversation, and both when to zoom in to say, let's look at that, let's see what nerves are involved or what different pathologies are involved. But let's also remember to, and what are the cultural teachings? What were the even family of origin lessons that were passed down, right? Hear your parents having sex? How did you hear about it? How did they talk? How did other people talk about it? Right, those learned expectations play a big role. What's supposed to happen? And then again, that factor of it's just go how it went in that movie. So the miseducation that most
right. Or things that, you learned from friends, or maybe have the misinformation, right? So, and I was just, a couple I saw recently, pretty female patient that had pain with intercourse. This is her partner actually came to every appointment, went through the treatments. She actually had a lot less pain with exam dilators, was able to really increase dilator size and get her pain down. I feel like now the piece is really getting her the intimacy part. So she's like, I feel like that physical part is better. It's just now I feel I just need that intimacy part, and what you really can help with too.
Yes. So approaching it almost, again, ideally it's if the partner can be initial set of all these treatments, right? So they're on the page, understanding and knowledge. They're on the same of working with the physical therapist. PT will allow a partner to come in. Okay, look, this is. But again, as you're saying, how do we go from that clinical piece to, okay, everything seems to be working. Now, how do we have fun?
Mm-hmm.
And so it's that behavioral conditioning, basically, of be mindful into, are we connecting? What am I feeling safe? Am I feeling relaxed? Am I feeling on? And what are we doing? How are we doing that?
Mm-hmm.
Versus, and kind of checking in, that mindful check-in of, okay, what kind of warm-up do we need technically, but then what warm-up do we need relationally, right? We'll have folks practice eye gazing, breath work together, and just talking, right? Talking about what turns them on, as well as what turns them off. And commonly there's the pointer finger. Well, you on went by ... or you turn me off when you, et cetera.
Yeah.
When you're pointing a finger, there's 3 more pointing back at you, right? So statements. I turn myself off by thinking about this roll or this freckle or this scar, or I turn myself off when I think about everything that you have. Right? Turn myself on when I imagine you doing this. Myself on for how much we love each other. It's to really make an inside job as much as it's a relationship. Physically, what the is an experience calming down, safe and relaxed with their partner present. Might have them do dilator work or even the music with their partner present, because then their brain goes, oh, okay, their partner person is not. I know this person shame me. I can't do X, Y. No. Again, the person might think that and feel that in spirit, but the body has a mind of its own, right?
Right.
If I got into an accident, right, I know cerebrally, no, it wasn't my car's fault. It wasn't my fault. And I know it was icy out and right now it's dry, but sometimes the body just can't get to do that again unless that slow gradual to relearn it. And that learned, your base learning can only be unlearned eventually. And so if the partner was not present during this whole healing process, she could be able to get a 6 dilator in he or she enters the picture as far as the partner.
Mm-hmm.
A whole new environment, right? And
right.
We'll feel like they start from scratch. But there is a gradual way to really connect all those dots for the patients, just to be one step.
Yes, all those pieces. I mean, how really thinking can change your emotions and your behavior. I mean, it's really, really amazing.
Yes. Yeah, I do. The wheel, the 4D wheel that I talk about sometimes during my mind days, live is the mind, body, heart, and spirit. And so I'll have patients literally write this circle that, 4 quadrants, mind, body, heart, spirit, and I have them put it on the floor, and I have them walk around and saying, okay, let's really try to understand all the different things going on. What do we know and what do we need? physically, what are all the sensations that are coming? And again, as you've said, both what hurts but what doesn't hurt, what isn't functioning but what is functioning.
Right.
And then the emotions around heart quadrant and the spirit quadrant being connection and disconnection. And so really breaking it up in that type of way help clients really delve deeper into their experience and say, no, think about that piece of it. And sometimes there's a hesitancy because there's that blame of, well, you're just saying head again. And then it's saying, no, the brain does not operate separately from the pelvic floor and vice versa. If they're plugged in. If it's happening here, it's happening here.
Right.
The nervous system travels at what? I think it's 240 miles an hour. So chicken and egg, it doesn't matter. Your experience is happening in both. And we want to give the resources to address both sides.
Yeah.
Let me check my checklist that I got here. See any other treatment that that PRM offers side that you touch on?
I think we touched on. I'll go over it again. But treatment really, we're evaluating the pelvis musculoskeletally, so really evaluating the pelvic floor muscles, the nerves, for any dysfunction or pain in the pelvis, but also looking at any underlying issues, so any hip pathology, lumbosacral spine pathology, hernias, any sign of sports hernia, athletic pubalgia, which can play a role as well. So we're really, and then how we really treat it is taking all that information and really kind of getting you into a therapy program, pelvic floor physical therapy, which helps to really work on the pelvic floor dysfunction. If you have those, most patients have tight or hypertonic pelvic floor, so it's really the tight, short, contracted pelvic floor, which we're essentially just trying to really relax and lengthen. And then also the nerves. So we're creating space in the pelvis for the nerves to function, to actually heal themselves and function appropriately and not be as irritated, as sensitized, really calming down those nerves in the pelvis. So we do a combination. So it's pelvic floor physical therapy. It's multimodal. It really works the best, multimodal approach. So it's a combination of pelvic floor physical therapy, sometimes muscle relaxant suppositories, and then some oral medications to really help with that, calm down the brain and that pain loop that's going on. We're breaking the cycle, down regulating that up-regulated nervous system. So sometimes getting oral medications just temporarily on board to really calm down the nervous system. And then all the physicians really do a series of injections. So it's ultrasound guided external injections, meaning that it's not intravaginal, it's not intrarectal, it's more kind of in the buttock area, I usually say, but definitely makes it tolerable. There's no downtime. The series of injections, so it's a combination of nerve blocks and trigger point injections. The nerve blocks are really opening up space for the nerve. It's more mechanical, so making space for the nerve to heal, but also using some medication to really decrease that inflammation, that sensitivity of the nerves. And then the trigger point injections specifically are targeting the muscles, so the muscles of the deeper pelvic floor muscles, so they're really relaxing those tight muscles. So really doing the injection series, working with pelvic floor therapists, and then using the medication suppositories really helps reset the muscles and nerves. So it really does, the majority of our patients really have a significant improvement and they get back to doing things that they love.
Yes, and I love, really highlight not the multimodal, but the multimodal approach, right?
Yeah.
Sometimes I like to say, well, I'll do the injections and then I'll see if I need PT. And then if I do this and this and this and it still doesn't work, then I'll go see Dr. Milspaw. The mind stuff always tends to be last, but what we're encouraging and what has really demonstrated in the research is that simultaneous.
Mm-hmm.
You need to retrain the floor both through the medical intervention and physical therapy at the same time, feeling the brain's reaction, the brain's of
Yes.
and the anticipation of pain, and that really allows both to be more effective, more efficient, and getting people back to connecting. So for those listening in, the Retrain Your Pelvic Pain course is a 6-week course that guides people through the and connecting dots and all the exercises that help retrain the system to get to become, it only takes about 10 to 14 days before we start the actual hardware changes in the brain that will hit the repeat when it comes to sensations, as well as associated thoughts, memories, etc. So there's the 6-week Retrain Your Pelvic Pain course, and then kind of once you graduate from that, that's when the Reigniting Intimacy course is ideal, because it talks about, okay, now that you know what you need to know for the self-healing, and have that zoomed out understanding, now let's talk about connection, pleasure, and intimacy, regardless of whether penetration is possible yet, because sometimes certainly the muscles take a few months to really heal. We can start having fun. We don't have to wait for penetration before we can really start connecting. And so Reigniting Intimacy course is all about. And so people can learn more about our services both on pelvicrehabilitation.com. I had that right, but certainly I know in the comments section or underneath our Instagram. Now I'm aging myself. I don't know what it's all called. Underneath the video, and they can connect. They can connect with me, and they can register for an appointment right online.
Sounds great.
Yes. Well, I hope to meet you in person someday. I think I'm going to be coming to Chicago next year at some point.
Good.
Pelvic Rehabilitation. That is the website. And thank you for joining us today. And thank you, Dr. Leishear, for your time.
Thank you very much. Thank you. I appreciate it.
Yes. Have a wonderful day, everybody.
Thanks. Have a good day.